My name is Gabriel Chodick, and I'm from Maccabi Healthcare Services in Israel. And thank you for the opportunity to present to you today Maccabi Tech and the Maccabi Institute for Research and Innovation. Talking about the data in Maccabi, the organization of the healthcare services in Israel, and finally, the big data and the use of big data in providing care and research at Maccabi. So first of all, for those who would like further information, there is a nice case study reported by the Harvard Business School last year. And this is the name of the case study, and you're more than welcome to search it and read it. So a word about the Israeli public healthcare system in Israel. Israel enjoys a universal health services for over 20 years now. The entire care is provided by 4 competing state-mandated health organizations. Maccabi is one of them. We provide a nationwide, countrywide services, and membership at Maccabi is free. Members are very free to join and leave with no limitations. We cannot bar anyone from joining Maccabi. And most of the services are provided by law at a minimum copay or completely free. Most of the funding comes from the general taxpayer money and the health taxation in Israel. Maccabi covers more than 2.2 million members. Actually, it's more like 2.5 million members today, where Clalit healthcare services are the largest HMOs, and the 2 smaller ones are Leumit and Mouchedet. So Maccabi is a non-for-profit organization, and it provides the public basket of services. On top of it, we also offer insurance for additional services. 85% of our members enjoy an additional coverage. So with 9,000 employees and 5,000 independent physicians, we provide care to the entire country. And luckily, less than 1% of our members are moving out of the network. So the retention rate is very, very high, and we can actually conduct retrospective studies going many years back with a very small proportion of loss to follow-up. Maccabi also owns the Asuta Medical Center, and it has contracts or ownership of over 700 pharmacies throughout Israel, and the total income budget is about $4.5 billion a year. Maccabi is the only non-US organization which is part of the Healthcare System Research Network in the US, and even in US standards, the Maccabi HMO is relatively large. It's the 3rd within the network, only after the Kaiser Permanentes in North and South California. So the major topic of today's presentation is Maccabi's central databases and the use of these databases. So all the data is transferred on a daily basis from the 5,000 physician clinics, nurses station, imaging center, physiotherapy clinics, all the lab collection points. Luckily, we have only one lab providing service to the entire network, so we have to deal only with one lab in terms of results. So there is no questions of calibrations and differences in methodologies. So this is the lab data. We also get the information from our 140 primary care clinics, the 32 general hospitals in Israel that hospitalize Maccabi members, and all pharmacies. Any prescriptions, all prescriptions are captured, both the prescribed and dispensed ones. So the cornerstone of the Maccabi clinical information system is the shared EMR. The EMR goes back to 1993. Every physician in Maccabi can log in and view every EMR of every patient from anywhere in the world. Everything is online. We have e-labs, e-prescriptions, e-consultation, namely physician can consult online about patients with the EMR open to both sides. Sometimes it happens during the visit, while the patient is not aware that the primary care physician is consulting with a secondary medicine physician. And we also have a physician portal where physicians can learn about their patient population and get some information about quality indicators and other types of data. So the data captured includes a very wide list of variables, including demographics, household members, mortality, physician diagnosis, all prescriptions, hospitalizations, visits to ER, lab tests, visits to nurses, and also imaging. A word about imaging: we have data of about 800,000 X-rays a year, 150,000 CTs, a similar number of MRIs, etc. So most of the data, and we talk about almost 2 petabytes of data in Maccabi, more than 90% are of imaging data. On top of the basic layer of data, we've developed disease registries where we define criteria of different diseases. And this set of criteria was used to identify the patients in the database and get the potential names of the patients who should be included in the registry. For instance, diabetes registries. The registry includes information about the diagnosis of diabetes, medications, specific labs, hospitalization, specific treatments and examinations that are given to diabetic patients. And once the list of potential members is ready, we reflect the information to the primary care physician who knows the patient best, and they have to validate whether the patient is or isn't a diabetic patient. And that's why we keep a very up-to-date and valid list of members who belong to the diabetes registry. Currently, we have 181 and 211 patients in this registry. Of course, the registry is updated on a daily basis. And if a patient, for instance, recovers from diabetes, for example, after a bariatric surgery, it is removed from the registry. So currently, we have several registries as indicated in this slide. Once we have the data, it's very easy to calculate the prevalence, age-specific, age and sex-specific prevalence rates of different diseases. And here one can see that, for instance, hypertension is very prevalent at the old age, with over 80% of our members aged 70 or above are having diagnosed hypertension. And since we also the payer for all services of a patient, rather than only insurer, we have all information of the cost of services. And this figure indicates the total cost of different chronic diseases. With hypertension, for instance, which is the light green here, the area under the curve, and this is for women, is about 9% of the total curve, which means that about 9% of our expenses goes for treating hypertension, which doesn't have a very expensive therapies, surgeries, or procedures, but yet the huge number of patients really drive a very high cost and burden of this disease, which really helps our management to allocate sufficient services and optimize care in hypertension in order to reduce cost and make the system more effective. Another example is BMI. We have currently, it's a mandatory information for every member to have his weight measured at least once a year. So here you can see the breakdown of different BMIs, including over 60,000 patients of underweight, about 700 patients normal weight, and the breakdown of obesity and overweight in Maccabi. So this is not a sample, this is the actual number of patients, which allowed us to really recognize that obesity is a natural thing. You can see here the distribution of BMI by age from age 18 to 85 and above. And you can see that the entire distribution really goes up and the blue line represents the BMI 25, which is the cutoff for overweight. We cannot talk about data without mentioning the coronavirus outbreak. And very quickly into the outbreak, Maccabi has collected information about members who were infected and tested for PCR. And here you can see the rise and decline of number of patients during the outbreak. You can see the distribution of age and sex and the proportion of patients who were found positive. And you can see that the highest number of daily patients was somewhere at early April, where the outbreak has started to decline. Using this data, and since we have individual level data, we could easily track the outbreak. And maybe I can show you a small clip showing the different areas. And this is a map of central Israel, with Tel Aviv located over here. And I'll show you the clip with this. Pay attention that this is day by day from March 1st, over a month. So please pay attention what happened. So furthermore, we were worried about the different risk factors that were suggested for infection. And also, we were curious to know whether some medications that were suggested as protective against COVID-19 are really help in protection. So very quickly, we conducted a case control study that is already published in Autoimmunity Reviews, comparing 1,300 patients who are positive and 13,000 patients who are negative for SARS-CoV-2. And once you adjust for age, sex, and other variables, one can see that hydroxychloroquine and colchicine are not related by any means to protective effect against COVID-19. And one can see that diabetes and BMI are positively associated with disease, as well as low socioeconomic areas. Another study that we found very important is whether ACE inhibitors are related to higher risk of infection. And again, using this kind of data, we found that there is no significant association between exposure with ACE inhibitor and ARBs with COVID-19. So we were quite relieved, and it really supports the recommendation of the European and US cardiology associations, recommending not continuing with these medications and not switching to other therapies in hypertensive patients. We are also intrigued whether we can identify an algorithm for complicated COVID-19, and indeed we found some risk variables, risk factors that could be assembled into a risk score to identify patients who are most likely to get complicated. For that, we also did a study comparing the COVID-19 based model with a previous model that was developed for influenza-like infection. And indeed, both models did a very good job. Here you can see that among 54 patients who were severely complicated with COVID-19, 44 were identified as high risk, which is very nice for an algorithm that was very quickly developed. On top of it, we also used our electronic questionnaire that were sent to all of our members, adult members, asking about symptoms. And this is the summary of the result by a team in the Weizmann Institute using those kind of questionnaires. This is published in Nature Medicine last month, and it really shows the use of those questionnaires to identify symptoms that are related with the infection, such as cough and fever, while it also was able to show that other symptoms are negative for COVID-19, such as nasal congestion. So on top of those descriptive studies, Maccabi Tech is aiming at developing the predictive and prescriptive studies. And one such development is K-Health. This is a automated symptom checker that was developed based on Maccabi data. They've collected all visits to physicians, which is 20 million a year. Over 20 years, that means that almost 400 million visits with all the free text from these visits. And using this, the team was able to develop an AI-based symptom checker that can be downloaded for free at your app store. Search for K-Health. And the bot here really asks you questions about symptoms. And the next question is really based upon the answer to the previous one. It's not a rule-based, it's based on deep learning methods. And after collecting all the symptoms in a very friendly way, the algorithm actually suggests a diagnosis with the likelihood. For instance, here, you can see that the algorithm suggests musculoskeletal chest pain and then a probability of 59%. So this is a freeware that everyone can use. It was downloaded by over 3 million people by now, and it was launched last year. And this is only the first case use. Next, in Maccabi, we're going to use this AI embedded in the EMR in order to collect information prior to visits to physicians. And once a physician gets the information, it's already organized with the relevant questions to have a very clear anamnesis and save visit time, which is very expensive, and also suggest diagnosis, treatments, and further investigation in order to validate the suggested diagnosis. And I think this is a really breakthrough in care and primary care in Maccabi. Another technology is digital pathology that was also developed within Maccabi in-house using the Maccabi pathology data, and it is already being used as a second read for negative result. Namely, if a only for prostate cancer, if a biopsy is defined as a negative by our pathology lab, the algorithm runs again over the slide and validates the result. And unfortunately or fortunately, it happened at least twice that a negative result was identified and sent for validation. Finally, I would like to talk about personalized medicine. While we have already the digital data, we're willing to get more information about the genetic and biologic data from our patients. And this is the reason why we opened the TIPA Biobank. This is a voluntary biobank where patients are being approached during the visits to our clinics and asked to join the biobank. Since we have only one lab, we can do it quite easily. And once the patient is opting in, every time he has a phlebotomy, one tube will be kept for research. Currently, we have over 120,000 patients opting in with a consent rate of about 50%. And this is the breakdown of the first 30,000 members with the mean age of 50 and some majority of females, about 60%. And I believe that within a year, we'll have in the EMR not only the phenotypic data, but also genotypic data, which really revolutionize the way that we treat our patients. And lastly, for researchers that are willing to search data, investigate in Maccabi data, we opened a research room that allows researchers from all over the world to log in and use our de-identified data. For details, please contact me directly. So thank you so much, and see you maybe next year face to face. Thank you.